Okay.
Great. As I already mentioned, I'm Nancy Henderson. I'm with Prisma Health Upstate, and so happy to be a part of this project related to foster care. And specifically today, in the next 30 minutes, hopefully we'll get a little bit of insight about identifying child abuse and neglect in your practice, and also with the foster care children that you might see coming into your practice for evaluation, especially for that initial evaluation.
I need to swap the screen here. I'm trying to figure out how to do that on here. There we go. Okay, sorry about that. We're ready now.
Okay, great. Maybe.
Are you able to see it?
I am able to see it, but I can't advance it.
Gotcha. There you go. Just let me know when you want the screen advanced.
Are you going to advance?
Yes, I can advance it.
Okay, all right, great. I have nothing to disclose. Go ahead. So as mentioned, for these next 30 minutes, we're going to talk about the role of the pediatrician identifying child maltreatment, look at some potential triggers of child maltreatment in your practice, and identify some factors that place children at risk for child maltreatment. Take a moment to just talk about sentinel injuries as early warning signs of abuse, and then identify some physical findings that may suggest both physical abuse and sexual abuse. Okay, go ahead. So we'll start with the poll question. How confident are you identifying physical abuse in your practice and reporting?
Okay, I have launched the poll. Everyone should see it on their screen so that you can respond to it. There was a little delay, so you should see it now. Okay, it looks like I have a majority of people. I'm going to leave it open for about 5 more seconds, and then we'll close the poll and I will share it. Okay, I'm going to end the poll and share it.
Okay, great.
Be able to see the results.
Yeah, so most confident could use some more training. Great, that's why we're here today. I think it's even a little bit more concerning when you actually have a patient in your exam room trying to figure out what to do and how to move forward. So thank you for that. So we got a little work to do today. Next slide. So this is just some data just to sort of set the stage about children coming into foster care in 2018 from Kids Count data. And I think nothing new, probably what you all know is that the majority of kids coming in are under 12, and a good portion of them are under 5. And that's a particular area that we have increased concerns about physical abuse. Just to sort of understand where they're coming in. I think for the older children, although the physical abuse may have happened early in life, it's still a part of who they are. So even though you might not be seeing them specifically for that reason, it still may be part of their story. Next slide. And I think when we break down, again, this is also KidsCat data, again, just like across the country, the majority of kids coming into foster care are coming in with neglect, followed by physical abuse, and to a much smaller extent is sexual abuse. I think the most important thing that I would say as a take-home message is that most times for children, it's not operating in and of itself. So most children that are presenting with neglect may also be victims of physical abuse, have been seen domestic violence, have parents that have drug and alcohol addictions, so perhaps some mental injury, perhaps some sexual abuse, and because of that may not be getting to school on time. Especially, I know in my practice, I am seeing so many kids that are supposedly learning virtually, but it really is unclear how much that is happening and how much even that is getting reported back to DSS in sort of this system that we're trying to work through. So important, even when a child comes in with their main concern about neglect, to really try to uncover and remove some of these other issues that may have happened for them, with them. Next slide. And why is this important? I think it's so important to really understand what has happened not only to children, but also to parents, is because that we clearly know that children that have been victims of abuse and neglect really sort of take that in as part of who they are. And a lot of times it becomes unresolved. They're 9 times more likely to get involved in criminal activity. We see that in adolescence and then going into adulthood. They are often taking on high-risk behaviors, whether that's early sexual activity, increased risk for STIs, and often more at risk to abuse their own children. And sometimes it's just because of the cycle of their own abuse and getting in high-risk relationships that sort of sets the stage for this to continue without people getting the appropriate mental health referrals and counseling that they need. And we also know that a lot of not only these children, but the parents also have quite a concerning history for depression and other mental health disorders related to this abuse. Next slide. So I think as sometimes I forget to remind myself that, there's not too many problems in pediatrics that is 100% preventable, and child abuse is one of those. So if we can, as pediatricians, do as much as we can to identify families that are at risk and trying to connect them to services within our communities, then the likelihood that we can have an impact on the abuse within that family is pretty substantial. We clearly know what some of those risk factors are. We're seeing it again a lot more during this pandemic, but poverty, food insecurity, homelessness, unaddressed mental health problems, unaddressed substance abuse, lack of employment, which is so high right now, intimate partner violence, isolation, which is again huge as we all had to shelter in place and then be without our jobs, our community, our support system, really puts not only adults at risk, but also the kids at risk as well. So really sort of thinking about social determinants of health, ACEs, and then the pandemic, which really I think puts everything sort of on fire as far as increased risk for the children that we're seeing. I think one of the things that we can do, not just for children that are coming into foster care, but all children with, and all parents, young parents, and some who may not have good mentors to know sort of normal childhood behavior, to help them recognize, normal colic, normal toilet training, when that's supposed to occur, how to put children to bed, what is appropriate development. Expecting a 2-year-old to sit still is so unreasonable. But for a parent, if they're expecting them to be able to do that, can be quite frustrating and more likely to involve corporal punishment as a way to sort of pull in some of that behavior. I think one of the things that we do know, that while corporal punishment is not an ACE that we actually see reported, it was an ACE that was studied from the earliest of the ACE study and really has been shown to have an impact on long-term outcomes in children and adults as well. And obviously, the biggest key why we look at some of these negative things going on in the home, we really from the get-go want to understand what are some of the strengths within the family and how do we build some of those protective factors. I know we all have seen, children coming in who have been through so much and they have been so resilient and trying to understand sort of what was it? What are those things that are helping to make it through? And often I have seen that it's often just having the connection to someone who believes in them, who is able to sort of move them through some of their needs, whether it's counseling, a safe place to be, and sort of allowing them to sort of work through the trauma and build on some of those strengths. Next slide. So just in focusing a little bit on the physical exam that particularly to child physical abuse, when should you be concerned? And you may want to just think about that as you're seeing, especially for that first visit of a child coming into foster care, when often you may or may not have the full story, but any kind of injury to a young preambulatory infant always raises a red flag. And we'll talk about that a little bit in the couple of slides to follow. But that includes bruises, mouth injuries, tears of the frenulum, fractures, intracranial and abdominal injury, unexplained vomiting, lethargy, irritability, apnea, and seizures. We know that those kids that come in that are not breathing and having seizures, they're not going to come into your practice. They're going to come into the ER, and all those studies are going to be done. But it may be those more sort of young children that don't have as severe symptoms, just fussy, not tolerating their feedings. Why that could be a common pediatric problem, it also can be a sign of head trauma. The child that has multiple organ system involvement, and then has always been sort of the hallmark for physical abuse is multiple injuries that we see within different stages of healing, whether that's bruises, burns, fractures, or combination of above. Obviously, when we see pattern injuries, most commonly a hand or a belt or a loop cord, really sort of takes us out of the ballpark of what are the things, do they have a bleeding problem, and really get more concerned that this is inflicted injury. And then trying to understand sort of when we start seeing bruises, where are they, and what's more common for accidental injury, and what's more common for inflicted injury, and look at that based on the age of the child and their developmental history. We're always trying to understand from the caretaker, which again, you may not know if it's a child in foster care that's just coming in for that initial exam, sort of what was the story, and does that story make sense? And if it doesn't make sense, then we really need to try to understand it and maybe evaluate a little bit further to figure out, is this inflicted, or was this an accident, or some other explanation, medical explanation. And then, as mentioned earlier, are there other signs of abuse going on? Child neglect, is a child, what are the growth parameters? Is there dental delay or excessive caries that may also be an indication of abuse, or educational neglect, which I think is something that we're going to be seeing over the months to come as we still continue to move through the pandemic. Next slide. So I just wanted to, if any of you have not actually read this article, is I think in 2015 by Dr. Sheets, who's a child abuse pediatrician, talking about sentinel injury. And she defines sentinel injury as that injury before the big injury in a young child, usually under 12 months of age, who really may be the hallmark sign that there is something significant going on, and can we identify that child, that family early on before something severe happens. Next slide. So in this particular study, they looked at 400 children, again, in that index area of less than 12 months of age that were evaluated for abuse. And what they saw was that 200 of them, so half of them, who had definite abuse. Of that 400, 30% had a previous sentinel injury. And what was that sentinel injury? Well, most commonly it was a bruise, not necessarily a significant bruise, but a bruise. It was an intraoral lesion, or it had some other area of concern. Subconjunctival hemorrhage was one of them. And the other important factor in this study, that the majority of these children were young, under 7 months of age. So again, when we see these type of concerns, bruising, intraoral lesions, subconjunctival hemorrhages, we really should get concerned about abuse and want to rule that out before we just sort of pass it off as, just something that can happen. But when they look back, why did not anything happen when the child was seen initially? The injury is minimal, so it didn't really raise that big red flag of a child coming in with seizures or apnea. The child wasn't coming in with a history of abuse and neglect, which is rarely the case when we see children evaluated for that. And we, as pediatricians, we often, majority of the time, believe the caretaker. We want to believe the best in parents and believe that they have the child's best interests at heart. And while a lot of time that is true, I think we all have had cases while it isn't. So we really, again, want to put the history together with the findings, together with the science and literature to decide, is there any more evaluation that needs to happen for this particular child? Next slide. So we know that the skeletal survey is something that we do use, especially in these young children, when we do have concerns about the possibility of abuse and neglect. So they may have a bruise, they may have one fracture, and then we're looking, are there other reasons of concern? And so that skeletal survey can be very, very helpful. I think to remember that, some places still do babygrams. That's not adequate to evaluate. If you are concerned about abuse and neglect, you want to do that follow-up skeletal survey in 2 weeks because sometimes you'll miss rib fractures, which won't show up on that initial x-ray, but we'll see healing. And then the classic metaphyseal fractures, which are hallmark for abuse, again, in that young age patient, we can see more clearly as we look at that follow-up x-ray. And we want to make sure, if we can, that the radiologists that are reading these x-rays are experienced at reading pediatric films, because sometimes the findings can be so subtle and difficult to pick up. So just to keep those facts in mind. Next slide. So this, I think, is a great acronym. If you haven't learned it, just put it there, 10-4 FACES P. It was done again by another ER doc, child abuse pediatrician, from just trying to identify when are bruises of concern. So the T is for torso, bruises on the ear, the neck, the frenulum, the angle of the jaw, the cheek, the eyelid, the sclera, any bruises so the 4 is any bruises in children less than 4 months of age, and then the P is for pattern injury. Next slide. Well, so this article, which is fairly old, back from 1999, Dr. Naomi Sugar had done a study looking, and the title is actually the best part of the study, Those Who Don't Cruise Rarely Bruise. So we definitely all remember that. And she looked at, in this study, she looked at children in the Well Child clinic under 3 years of age. And what she found that about 20% of the total sample had bruises. But again, in this highest risk population, bruises were really rare in the children less than 6 months of age. So real red flag as they come into your clinic, whether in foster care or in the general pediatric population. Next slide. So we're now going to transition to sexual abuse. So a similar slide to just sort of get an idea of your experience with this. Go ahead and do the poll, Shoshana.
I've started the launch. It looks like there's a bit of a delay. You should see it now. Going to leave it open for about 8 more seconds. All right, and I'm going to be ending the poll. I'm going to share with the results now. You should see them.
Yeah, thank you. So I think this just, I think there is a little sort of transition to the lower C and D of the answers in this slide. And I think it really reminds us why Children Advocacy Centers got started, because it really initially was to identify child sexual abuse, which pediatricians often, one, feel a little bit less comfortable with. And secondly, we know that there's not a lot of findings that we just don't see on our physical exam. So we are needing sort of other resources to help us identify children that may be at risk for sexual abuse. Next slide. So I think the components of child sexual abuse, I think the most important thing is once you have a verbal child is what they have to say. What is their story? And that could be really mind-opening and identifying what has happened to them. Sometimes they get identified because of the behavioral indicators. Children are touching other children. They're performing sexual acts that really are way above what they should know based on their age. And that could really give us insight as to what is going on. Sometimes there is medical evidence, and that could help us. Sometimes we'll have cases related to an STI, and we'll work backwards from that. Or I'll have a child presenting with genital trauma and work backwards from that to try to identify what happens. STIs in young children are not very common, but we often do check for them, and we'll talk about that in a minute. And sometimes they will come in if the abuse happened within the first 36 hours in young children under 11 to have an evidence kit collected. Next slide. So I think I'm not going to go over this entire slide. I think this is a really helpful guide. There's always questions, you know, when parents come in and say, you know, my child is doing this. Is that normal, or should I be concerned that something happened to them had they been sexually abused? And so you can look at that last column there, which I think is very, very helpful. So sexual acts that are way above sort of their age, children that can't be redirected while they're either doing some self-stimulation or touching other children, or are very aggressive in their acts, are rarely normal and often warrant further evaluation. And sometimes you'll have foster parents coming in and they are seeing some of these acts and will say, I'm concerned. I don't know if there has been worries about sexual abuse, but this is what I'm seeing. You know, what should we do? So I think this is important information. Next slide. So I think the Children's Advocacy Centers, there's a link on the reference slide at the end to just help you identify what's the local CAC that's going to be closest to you when you have concerns about either physical abuse, sexual abuse, as you're evaluating either a child in your practice or a child from foster care in your practice who might need further evaluation for this. They are child-focused, friendly facilities, and they bring together law enforcement, DSS, mental health, medical, often mental counseling. After that, MDT, multidisciplinary team evaluations to help figure out, you know, what are the concerns, what happened, and how do we evaluate the child fully and maybe prosecute if needed. Next slide. I just wanted to bring you just a few pictures if you haven't seen a CAC. This is the one in Greenville, the Julie Valentine Center, just to show. It was an old carpet warehouse that got renovated. So we have so many different types of CACs across our state, and everyone is sort of unique to the community that they're in, but really are there all for the same purpose, to help support the community in trying to evaluate abuse and neglect along with the pediatrician. Next slide. So there's places to interview, there's places for law enforcement and DSS to watch the interview. We use the colposcope to document any of our findings on our physical exam. Next slide. Just to quickly go through just some of the things that we do on our exam. Kids really are pretty cooperative. We have a child life specialist to help us look. We don't use a speculum in the prepubertal child. We really can see exactly what we need to see, and we often will put in the knee chest if we see some abnormalities. Next slide. Again, this is another study done by Dr. Adams. Again, it's an old study, but the title really says it all, that children evaluated for child sexual abuse, it's normal to be normal. And so only about 14%, and even now, I think it's even thought to be less, that in chronic exams, maybe somewhere between 3 to 5% have abnormal exams. So I think it's important for families sort of not to like have their bated breath waiting for your exam to say, this is going to find whether this child has been abused or not. And the answer is no. We need to look at lots of other things to help us evaluate these situations. Next slide. So as mentioned before, we look at the child's behavior. The physical exam infrequently is diagnostic, but often very helpful for the child and for the family to know that everything's okay, or to check for STIs as needed. Basically the reason that a lot of sexual acts do not cause physical evidence, and children, unlike adolescents and adults, often won't be in a medical situation very quickly. So our body has very rapid ways of healing if it did have trauma early on, and we don't see it on our evaluation. Next slide. And I know these slides will be available to you soon. So just in case you have some questions related to STI testing in the prepubertal child, I just wanted to put up some of the sort of risk factors that may make you think about doing testing. Next slide. This is from the Academy of Pediatrics. What type of tests are most concerning for child sexual abuse? Next slide. And I think the most important thing that instead of doing swabs like we did in the olden days, we can use nucleic acid amplification test to test for GC, chlamydia, and trichomonas. And for GC and chlamydia, the most important thing is that we want to do, if we do get a positive test for chlamydia, we want to make sure that we test on a second site. And for gonorrhea, we want to make sure that if there is a positive initial net, we want to do a culture or a repeat on a second site for GC. Next slide. So here are the references, and I'm sorry, this one didn't have the additional sort of referral to the Scammers website, but if you just Google that, you can get a listing of all the CACs throughout the state. They also have a great PowerPoint on mandated reporting for yourselves, or really for any of the trainees that come into your office to get a certification for if you ever need that kind of training. There's no cost involved. It's really good about how to go through the steps with that. And with that, I'll end this conversation.
Thank you, Dr. Henderson. We have maybe a minute